cervical cancer screening is non-negotiable in the vaccination era? Many people question कि भाई इसकी क्या जरूरत है स्क्रीनिंग की जबकि वैक्सीनेशन हो रहा है. तो I think all of us should have one voice, and this is my viewpoint, and I'm not sure what is your viewpoint, but I will definitely say that our viewpoint is that screening has to go along with vaccination. This is WHO mantra, 90, 70, 90. I don't have to really dilate on this. All of us know about it. The hard facts are, HPV vaccination is a primary prevention. It makes the base of the whole prevention program. Screening is the secondary prevention. They are complementary and not substitutable. Vaccination prevents future infections, while screening prevents current infections from progressing to cancer. That's the very idea. WHO, looking at the example of the Western world, which are very close to be declared cervical cancer free. I'm told Spain will be the first one, then many European countries, including Australia. And WHO leadership thought about it, that if these countries who are high-income countries, they can think of their country to be cervical cancer free, if that strategy is also followed by the low-income groups and the middle-income group countries, they also can think about eliminating cervical cancer. So I say that, you know, they gave a lollipop to countries like India, who till now had been a low-income group and now is entering into middle-income group. But हमारे देश की हालत सभी को मालूम है क्या inside है. The 90-70-90 targets are interlocked. The 70% screening target is the crucial bridge between vaccination. 90% of the adults and girls by the government should be taken care, and the treatment, 90% of identified cases should be treated. We all know there's a long lag period. It takes 15 to 20 years for HPV infection to progress to cancer in immunocompetent women. पहले कहते 10 साल, आप कहते 15-20 साल लगते इसको कैंसर बनने में. But अगर आप immunocompromised हो, this can be duration can be shortened to 5-6 years also. Millions of adult women are already HPV exposed. Millions, and need protection today. Vaccine, we all know that the current vaccines protect against 90% of cancer causing HPV types. The majority of the vaccine has 16 and 18, and the screening catches cancers caused by other high-risk types like 31, 33, 45, 52, and 58. Now, there is a generation gap. Women who are 30, the primary screening cohort, are largely unvaccinated. They represent the entire at-risk population for the next 2-3 decades. इनका वैक्सीनेशन हुआ नहीं, खाली हम इनको स्क्रीनिंग कर रहे हैं, और we are picking up pre-cancerous lesion of the cervix. उनका अगर ट्रीटमेंट नहीं करेंगे तो they will land up in cancer. And as you all know, if you walk in any cancer units, cervical cancer patients are plenty, and they have 50% mortality because they come very late, usually in stage 3. Vaccine efficacy is high, but not absolute. I again repeat, vaccine efficacy is high, but not absolute. No vaccine can claim to be 100% effective. Breakthrough infections, cancers, though very, very rare, will occur. Screening is the safety net. to pick up those precancerous lesions and get them treated. Herd immunity takes time and a high coverage it requires in the population. India's vaccination drive is new. We cannot rely on herd protection for adult women. As far as our estimate for how many people have had cervical cancer in our country, I will say it is around 1%. The screening is 3%, and for many years it has been 3%. Every time the updated version is either 3% or 2.8%. And this requires challenges both for HPV vaccination, unless the government chips in to give adolescent vaccination to adolescent girls. I think it is not possible. And that's why the figure remains around 1%. Twice the government has recognized, announced, both in 2024, again in 2025 in the parliament, that HPV vaccination are coming and they will be giving to the adolescent girls, but the date has not arrived as yet. The evidence, what science tells us today. The real world data from vaccinated nations like Australia, the UK with high HPV vaccination coverage for over 15 years still maintain and emphasize organized cervical screening programs. None of the countries have advocated, none of the experts have advocated the cervical screening program can be taken away. They have simply evolved to the best, from cytology to the best, that is primary HPV vaccination. The HPV vaccination, this primary HPV testing is only introduced now. Earlier it was pap smear for the last 60 years, and with that also 80% of new HPV infections, they were picked up. And now this pap smear has been replaced by primary HPV testing. They also feel that both are complementary to each other and it is not time to take away the screening. The extended dose interval is possible and screening. With the move to single dose HPV vaccine schedule, which is again not followed universally, it has been recommended by WHO that up to 20 years you can give one dose of vaccine. Because what they found in 150 countries where the program was going on, the second dose was given only in 13% of cases because of paucity of funds or whatever may the reason. That is why the WHO SAGE recommended that if one dose is as efficacious as 2 doses or 3 doses, the monitoring long-term efficacy is vital, especially people who are vaccinated. Screening provides population-level surveillance data. Vaccinated women have a lower risk, but not a zero risk. I repeat again, vaccinated women have a lower risk of developing cervical cancer, but not a zero risk. Studies show vaccinated women have dramatically lower risk of CIN2 lesions, but guidelines do not recommend stopping screening for them. Screening intervals can be safely extended for the vaccinated, and this is the future benefit they can have. Evidence suggests vaccinated cohorts may need screening less frequently, but cannot be eliminated altogether. This makes the program more efficient. Primary HPV testing is the gold standard. In our Government of India program also, the primary HPV screening, 2 techniques have been confirmed in 3-4 centers, including All India Institute of Medical Sciences, and now they are in commercial preparations. So I think it will take another 6 months, and somewhere in 2026, they will be available for use by each one of us. WHO now recommends primary HPV testing as the preferred screening method. It is more sensitive than the pap smear and allows for a longer safe intervals, that is 5 to 10 years, and is perfect fit. अभी तक तो ये है कि आपने पैप स्मीयर और एचपीवी किया है तो 5 साल, अगर दोनों नेगेटिव है तो 5 साल का गैप आप ले सकते हैं. प्राइमरी एचपीवी वैक्सीनेशन के बाद भी एक्सपेक्ट कर रहे हैं कि गाइडलाइंस बाय द एक्सपर्ट्स विल कम दैट द गैप कैन बी इंक्रीज फ्रॉम 5 years to 10 years, and it will be a perfect fit for the scalable national programs. The self-sampling is game changer. Again, it has been found in a periphery that it is not possible for women in the villages and in the slums and otherwise also to bring them over for screening. But if you give them primary HPV vaccination kit for self-sampling, it has been found that it has been pretty good. The strong evidence shows the self-collected vaginal samples of HPV testing are highly accurate and increase uptake by overcoming barriers of stigma, access, and the provider dependency. WHO endorses it. Unlike breast cancer, there is a stigma in people's mind कि कहाँ के लिए जा रहे हो, cervical cancer screening के लिए जा रहे हैं, तो उनको अजीब सा लगता है. Screen and treat strategies work. We all know in low resource setting, a positive HPV test followed by immediate treatment is like thermal ablation in the same visit is recommended. हमारे अभी HPV टेस्ट एक्सक्लूसिव तो आया नहीं, तो हम लोग कहते हैं अगर VIA विली कर लोगे तो भी बहुत अच्छा है. But that also is not possible, and whatever the government figures I have already told you, it is less than 3%. This is highly effective see and treat model कि उसी विजिट में आओ, सिंगल विजिट में आप अपने को स्क्रीन कराओ, अपना the doctors makes up the mind and then they give the treatment in the same sitting, and this model is highly effective for countries like us where 2 follow-up or 3 consecutive follow-up for cervical cancer prevention is very difficult. Reducing loss to follow-up, which is big one. Now addressing the myths, appealing counter arguments. बहुत लोग कहते हैं myth is कि vaccination makes screening obsolete. The fact is, it is dangerous misconception. It is like saying seatbelt are obsolete because we have airbags. We need both for maximum protection. Another myth is screening is too costly. The fact is the economic evidence is clear. Screening is cost saving. Treating invasive cervical cancer is exponentially more expensive than it is amounting in lakhs, while it can be done in few hundreds for the health system and the catastrophic for the family in case if the cancer develops. So prevention is much better than cure. Third myth is let focus only on the young. So the fact is this abandons a generation of mothers and the caregivers. A cervical cancer Mukta Bharat cannot be achieved by leaving millions of women in their 30s, 40s, and 50s. So appeal to equity, vaccination reaches young girls in schools. Screening is our tool to reach marginalized older women in rural areas and urban slums, the very groups with the lowest access to healthcare. Missed cohort is huge. The woman aged between 30 to 50 today will be the main cervical cancer burden for the next 20-30 years. I repeat again. जो आज की woman आज की 30 से 50 साल की उम्र में हैं, they will be the main cervical cancer burden for the next 2 to 3 decades. They are the immediate priority for screening. In the Indian caste context, what is way for 90-70-90? India burden is now, we know that it is India's burden is 1/5 of the global cervical cancer deaths. Not only we have 1/4 of the total number of cervical cancer, as for the deaths are concerned, we have 1/5 of the total global deaths of the cervical cancer. We cannot wait 30 years for vaccination's full effect. Screening is our most powerful immediate weapon. Ayushman Bharat, health wellness centers are the platform. The existing network of health and wellness centers and Ayushman Bharat can be the backbone for organized screening, delivery, and for financing. Technology is the accelerator. Point of care HPV test, AI assisted digital cytology, VIA, digital health records can make screening scalable, quality assured, and linked to treatment. मैंने एक VIA का AI model देखा था, and the cost was exorbitant. They were asking 6 lakhs of rupees. Though the interpretation will, in a 5 minutes time, the computer will tell कि ये picture आई है तो इसकी diagnosis ये है. But the cost is so much that in a place like Delhi, cryocautery is available with 10% of the gynecologist. And VIA Billy, again, not more than 5% of the gynecologists are doing. I will not mention about the pap smear, how many people are doing. The government speaks very loud and says the screening rate in today's time is less than 3%. The catch-up vaccination question. While we vaccine 9 to 14, we must screen women at age 30 plus, 35 and 40. This two-pronged attack is the only way to bend the incidence curve of cervical cancer quickly. Community health workers, that is ASHA, are the key. Evidence shows that the trained ASHAs can brilliantly conduct awareness, mobilize for screening, and even facilitate self-sampling, linking communities to the system. Male engagement is crucial. Cervical cancer is a family issue, appealing to husbands and the sons to support the mother, support the woman in their lives to get screened, break stigma, and that will only increase the uptake of screening. Call to action for cervical cancer Mukt Bharat in our country. Reframe the narrative. And what should be the narrative in the public? Move from either or and with lagana padega. Vaccination and cervical screening. Vaccination and screening. Celebrate the vaccine, but champion screening with equal vigor is important. Vaccine bhi lena hai, screening bhi karna hai. So the targeting messaging is to policymakers, screening is the smart investment that saves life and money. And to the woman, get your daughters vaccinated and get yourself screened. That is the complete protection. Learn from the success models. Look to Sikkim, screening drives and lessons from the countries like Thailand, which integrated vaccination with scaled screening. Our historic opportunities is that we have strategy of 90-70-90, accepted in 2019. The tools are vaccines, HPV test, self-sampling, things like pap smear, VIA, Willy, and we have the platform of Ayushman Bharat and health wellness centers. The only missing piece is unwavering commitment. That is lacking. There's at the moment lack of political will and equally lack of enthusiasm among gynecologists. Let's not question the why of screening, but accelerate the how. The final rallying point is, for a true cervical cancer Mukt Bharat, we must run the vaccination and the screening programs on two parallel tracks with the same urgency and determination. The goal is within reach if we act on the evidence today. We have to act on the evidence. Thank you very much.